Leslie, I'll share my screen and we can go from there.
Go for it, Susan.
Do you want me to wait, Taylor, till you record? Is it already recorded? It's already gone. Okay. All right. Welcome, everybody. Thank you for joining our breakout session. I'm here with Dr. Leslie Rubin. My name is Dr. Susan Brasher, and we're going to be talking about autism and healthcare. And just to give you a little bit about each one of us, my background is as a pediatric registered nurse and a pediatric nurse practitioner. And then I obtained my PhD in neurodevelopment and in nursing as well. And Dr. Rubin, as you could see on the screen, if you want to say a little bit about yourself, he's a developmental pediatrician. Oh, you're muted.
Yes, indeed. I'm a developmental pediatrician, and I spend a lot of time seeing children and families on the autism spectrum.
Yes. And you have your own clinic out in the community, but you also work at Hugh Spalding, correct?
Correct. I do have a private practice in Sandy Springs. I have a clinic for children with autism and other clinics for children with cerebral palsy at the Hugh Spalding Children's Hospital downtown. And I also consult to a public health clinic in Gainesville, Georgia.
Great. And I'm affiliated with Emory School of Nursing. So today we wanted to talk a little bit about just the healthcare in general and routine healthcare, and then we'll talk just about some from a parent's perspective, but from also a provider's perspective. So for the routine healthcare, we all know it's very important for us to maintain our routine healthcare, and going to those well child visits is so critically important, but that's easier said than done. And so healthcare visits can be very stressful to the child and also very stressful to the parents as well. So we wanted to talk about some of those stresses, and then what could we be doing as providers, as clinicians, as parents to minimize some of that stress. So here are just some ways that we can help with our families to help better prepare them for the visits, because we find that parents say the more that they prepare for their healthcare visits, the smoother that healthcare visit goes, and so the more successful it is. So these were just some tips that we pulled together from what we've heard from our parents that have really helped with having their child going to their healthcare visits, or by preparing ahead of time, by reading them social stories or books that explained a little bit about what was going to be happening at a healthcare visit to kind of increase the familiarity of the visit. Also having the parents just take a drive. Some parents would say that even just driving to the building or just getting into the car to say, we're going to the visit, this is what it's going to look like, we're going to get on this highway and then we're going to go this direction, that helped to decrease some of the fears of the child. Practicing at home, so using dolls and stuffed animals and even just each other, and just saying, they have just like little Doc McStuffins kits with, or little stethoscopes from Fisher-Price, etc., to just say, then what they're going to do is they're going to have to go underneath your shirt to listen because they can't hear it through the shirt. And so kind of practicing some of these techniques that can be sometimes stressful. And then describing some of the things that are going to happen. So when we first get there, you're going to be in the waiting room perhaps, and then they're going to call us back, and then they're going to get your weight. So you're going to be staying on a scale. And so kind of walking through some of the steps, again, just to increase the familiarity of the child to the visit. And then bring favorite items that will comfort the child. So talking to the parents about whether it's the Matchbox cars or if it's a stuffed animal, anything that is going to help to comfort them and distract them during the visit. And then here's an example of just kind of some picture exchange card systems, or PECs, or also visual schedules are very helpful. But this is PECs that can say, we're going to the doctor. And these are just some things that they can point to and kind of explain what's going to be happening during the visit. And then I don't know if you can see this very well, but this is an example of kind of a visual schedule that I have here. And so it'll say nurse, weight, blood pressure, and then vision test. And so there's these visual schedules that when you're done, they can flip that down, say, okay, I saw the nurse, all done with that. And then you could flip it down for the weight, and then you could flip it. And this just helps them to say, like, checking those boxes, right? And then all done with that part of the visit. So it helps them to feel like they have more control over the situation and decreases their anxiety. And so just again, some more tips of for parents that we encourage them to think about the timing of the visit. And so that our parents say that they often will try to have visits that are scheduled maybe at the very first part of the day or maybe right after lunch. And so working with the clinic to find out when is your less busy time during the day and how do I get a slot during that time? So not at the peak hours where there's a lot of people and a lot of noises and a lot of commotion. So that's one thing parents can do. Communicating with the clinic their child's needs. And so just kind of having that conversation with the front office staff, but also with the entire clinic of like, this is my child, Johnny. These are some things. Johnny doesn't like X, Y, and Z, or he prefers this, this, and this. Asking for accommodations. And so if it's possible, try maybe, for example, they don't want the room that's right next to the waiting room where you hear all the kids playing and screaming and crying, or so thinking about the location of the room and asking for preferences. Or maybe there's a room that child had found particularly triggering in the past, like it was too overwhelming with maybe the details of the room. And so like maybe not the dinosaur room that terrified my child. So could we not have that? And then again, like I said, just the likes, the dislikes, the triggers, having that conversation of what's kind of what their child prefers, and then how is their child's best form of communication, and whether that's verbally or whether that's the card systems or a device or a tablet. All of those are really important for the parents to have that conversation. So for the provider side, I always, whether you in the audience right now are a parent or a provider, if you're a parent, you could take this information back to your provider. And if you're a provider, hopefully you'll try some of these tips on how to make this a more successful healthcare visit, is that to allow extra time for assessment and procedures. So this is not the patient that you want to rush through and hurry up and get through the assessment. By doing so, that's only going to increase their anxiety, and then there's going to be more likely to lead to a meltdown. So take a little bit of extra time on the assessment and the procedure. But with that said, it's like a dance. It's like there's a time to speed up and there's a time to slow down. And so at some points, there's a point in the procedure that you realize that you're doing everything you can and it's the child's still having a hard time, then let's just quickly move through this piece of that then. And then using the patient's preferred forms of communication to interact with them is very important. If possible, provide them a choice. And so, I need to look in your ears. Do you want me to look in your right ear, or do you want me to look in your left ear? So that's a choice that they could have. And it's not a yes or no, it's a which one. Yes. Oh, I just heard a little noise, but I guess, okay. Use simple, direct, plain, concrete language. And so not overly verbose and a lot of flowery language. So just very simple language, very clear. Say what you're going to do before you actually do it. And so now I'm going to listen to your heart. And so give them a little bit of time to prepare for that step that you're about to be doing. And then provide distraction when possible. So whether it's those toys or whether it's what they brought to the visit. So something to distract them while you're doing it so that you can get through the assessment. When possible, it's really important to accommodate their sensory needs. And I say when possible, like for example, the dimming of the lights of the room. Some offices may not have a dimmable light system, so that may not be possible, but maybe you could turn the lights off and open the door to the outside area, and then that kind of is a way of dimming the lights. So think about the location of the room, and if we can put that patient in a room that's not in a high sensory area, that would be better. Limit the number of staff involved. And so sometimes people come in all at once to give immunizations, and one person's doing something else and another person's doing the assessment. It's just a lot of people in a small area, and it can be overwhelming for the child or young adult with autism. Speak a little bit more quietly, considering that they may have some auditory sensory triggers. Avoid perfumes and colognes. In general, a lot of children, but also children particularly with autism, are aversive to really strong smelling colognes and perfumes, so be cognizant of that. and then including the patient, but also the family. So always making sure that we're talking with the patient and not ignoring the patient, but also including the parents as well. So it's kind of a big family-centered care approach. And I'll hand it over to Leslie now, who could talk about some of the concerns we hear from parents that commonly occur in children with autism and maybe some things to consider.
Thanks, Susan. Hi, everybody. The list we have here include the feeding, nutrition, immunizations, their symptoms, physical health, mental health. So I just want to start off with immunizations, which is so important. And the sad thing is that some people are against vaccines. And it's so weird that they should be against vaccines, because vaccines save lives. And particularly the MMR vaccine, which has saved not only lives, but has saved people with autism, because the the R of the MMR is rubella. And in the mid-1960s, there was a rubella epidemic. And many women who were pregnant and became infected with the rubella virus had infants who had hearing impairments and autism. So it's weird that they should say that the rubella vaccine causes autism, because not only does it not cause autism, it prevents autism. So that's another story in its own. That's a whole lecture for an hour. So kids must have immunization. Some parents are anxious and some parents want it staggered, and that's fine. The second thing is feeding and nutrition. The kids on the autism spectrum happen to be the pickiest eaters in the world. They're the ones who will eat only chicken nuggets from McDonald's and no other place. They will eat macaroni cheese and only from the Kraft box. They will eat pizza though, and some kids will pick the pieces off and eat them individually, and they do like French fries. So that I always say to the parents, the 4 food groups are chicken nuggets, macaroni cheese, pizza, and French fries, the 4 food groups. Now, the other thing that's interesting is texture. So it's not only food, taste, texture, color. So these kids will also eat cereal without milk or pasta without sauce. Now, I'm not saying that's all the kids, but these are just some variations on the theme. And this drives parents crazy. In fact, one of the things that makes mothers most worried is their child's picky eating, because it's so natural for a parent to nurture the child with food. But when these kids are very picky, it's almost like a rejection. So I reassure the parents by showing them the growth chart. And invariably, these kids are growing very nicely. They're proceeding nicely on their growth charts. And so part of our physical exam always is measuring your height and your weight and your head circumference. And I like to show parents how their kids are growing nicely, particularly if they're concerned about eating habits. It's very rare. In fact, I've not had experience with this, so I say it's very rare that any child will land up with some kind of nutritional deficiency. As some miraculously, they seem to be nutritionally satisfactory. Now, what's important, obviously, and as Susan mentioned, is physical health and mental health. But what I want to do is just go into the exhibiting symptoms differently. So what I'm going to do is, over the next couple of slides, I'm going to go into the physical health, the mental health, and the symptomatology. Okay, number 1. Kids on the autism spectrum are much more likely to have neurological problems. Susan, can you just go back so we just keep the neurological? Okay, yeah, we'll just keep that for the moment. So the autism, the condition of autism is actually a result of unusual wiring in the brain in certain areas, often in the limbic system and sometimes in the occipital cortex area. But what's important is that because it's neurological, they can have additional neurological difficulties. And although tics are not common, children on the autism spectrum are more likely to have tics. Tics are repetitive movements that do not have major consequences on their own, but may have some social stigmata. The second is seizures, and seizures are much more serious. And not all kids have seizures, a small percentage, but greater than in the general population. Obviously, the seizures need to be identified early and treated properly, as any other seizure needs to be treated with medication. Sometimes it's tricky to diagnose them because sometimes kids have staring spells that are not seizures and may be mistaken for seizures, but they should all be evaluated thoroughly, because you don't want to miss anything. So that's the story of the neurological. Next one, Susan. The other thing that kids on the autism spectrum have a lot of is gastrointestinal disorders. Many kids will have constipation. It's one of the more common gastrointestinal disorders, and they might also have gastroesophageal reflux. Now, the problem with both gastroesophageal reflux and constipation is that the kids may not be able to express their symptoms of, let's say, burning sensation from reflux, or that they haven't had a bowel movement and they had some stomach ache. And here is exactly where the expression of the symptoms of the distress and discomfort may not be classic. So this is where children may exhibit behavior challenges that reflect some gastrointestinal disorders. And the problem with this is it's so hard to tell whether it's the emotional, social, environmental, or it's internal, physical. So once you've ruled everything out, if you still suspect that there may be some heartburn or some constipation, then just be on the lookout for that. It's not easy to diagnose. It's not easy to identify, but if there are some unusual patterns of behaviors and behavior disorders, you might want to consider that gastrointestinal disorders and discuss this with the pediatricians. Next slide, thanks. And I just wanted to point out that there are many genetic conditions that may be associated with autism, the most common of which is the Fragile X syndrome, but also Down syndrome. So children with Down syndrome are more likely to be on the autism spectrum than the general population. And it's sometimes very confusing because some people say some of the behavior patterns are associated with Down syndrome, when if you take a step back, that it's much more associated with the autism spectrum. And there are some there are some families who have many individuals in the family who are on the autism spectrum. Sometimes we can find a genetic marker and sometimes not, but that's just the way it goes. We're still learning a lot about the genetics of autism. Next slide, please, Susan. Thanks. All right, so this part is about, you can go click the next one. This is about going to sleep. And, you know, sleep disorders are common in the general population. The drugstores sell a lot of sleep medication. And in general, typical kids might have difficulty going to sleep. Some have difficulty staying asleep. They might wet their bed. They might walk in their sleep. Often kids will wake up in the middle of the night and go to their parents' room or be afraid. Some kids will have night terrors. So there's a whole lot of different patterns of sleep disorders. The problem is that for children on the autism spectrum, these patterns of sleep disorders may be more common, and they may be a little more dramatic and difficult to treat. So the important thing is to recognize that there is a disorder in sleep, and if you're having difficulty, the good news is that there are some sleep doctors who could help, and the best is to have routine. The best is to say, at this point in time, you go to bed, we'll tuck you in, you'll brush your teeth, we'll read you a story, so that it becomes a routine, so that there's a comfort and predictability. And one of the other things about children on the autism spectrum is that they do like predictability. And as Susan was saying about the physical examination, it really helps to tell them exactly what's going to happen. Because one of the big problems, yes, you can go to the next one, Susan, thanks. One of the big problems with children on the autism spectrum is that they have very labile emotions. They can't control their emotions very easily. So if they're anxious, they become more anxious. If they're obsessed with something, they tend to become more obsessed with something. If they have some distractibility and impulsivity, they may be more distractible and more impulsive. And if they have a dramatic emotional reaction like a tantrum, it usually becomes a meltdown. So the emotional reactions are much more dramatic and much more dramatically expressed than you would find in typical children. But the way to help them with any of these is more with, like Susan said about the room in the doctor's office, it should be calm, it should be quiet. They do much better with quiet, calm, predictability, routine. And if the routine is going to be changed, it's always helpful to warn the child, we're going to do this tomorrow, and you might need to say it multiple times. Also, obviously, for any of these conditions, there may be a need for medications. I won't go into that at all at the moment. If you have any questions, I'll be happy to answer them. The last slide, please, Susan. Oh, yeah, right. That's it. Okay, there we go. Right. Susan and I are available for you for questions. Right, Susan?
Yeah, I think now at this point, we just wanted to kind of open it up to you guys, and we wanted to hear from you maybe a little bit more of, kind of any questions you had, any suggestions you had, and maybe what's your role? Are you a parent or a provider?
Oh, that's such a good idea. Susan, do you want to take off the screen, showing the screen? No, perfect.
So I think somebody was going to go.
Sadell, I have
Yeah.
a question. Being as I am a carrier of rubella, having had a shot so many years ago, and it still shows up in my blood work, is that maybe a trigger for a child and a propensity toward autism or anything like that?
No, it is actually a protection against rubella.
Okay. Okay.
So you had the good news was you had the rubella vaccine, so you're protected against rubella. So should you have any pregnancies, it's nearly impossible that you will get rubella, and therefore your child is protected.
It's more of a, the antibodies are more protective. Mm-hmm.
Okay. I just wondered about that because doctors were shocked when they saw that in my blood work because I had the shot back when I was woohoo, Yeah.
Well, as Susan said, it's good that you have, because vaccines help your body to create what are called antibodies, and the antibodies are the ones that don't let the viruses come into your body. They protect you against the viruses.
Okay. Thank you.
So, hello.
Can you talk a little? Can you talk a little bit
Janice, and then Laura.
Yeah. Can you talk? I am a teacher. I work with what was the old PsychoEd network, GNETs, with high school students. And one of the things that parents often ask about and worry about is if they've managed to get their child to a pediatrician who is sufficiently cognitive of the issues that are involved with autism. The issue now is, what do we do when they're ready to move on to an adult provider? So I don't know if anyone's got any wisdom to say about that, but.
Susan, you have some thoughts?
Yeah, that's something where I have a grant right now trying to work on that, because it is a problem of this transition to adulthood of the pediatricians, that of all the providers that are going to receive the training for autism, it's more likely to be the pediatricians or the pediatric side than an adult side. So we hear that our adult providers don't get as much training as our pediatric side. So we find that that we're hearing from our patients and our parents that once they leave the pediatric side, so example, like I'm a pediatric nurse practitioner, Leslie, pediatrician development, my protocol says I cannot see them after 21. And so we were hearing that after they left my office and many other pediatricians and pediatric nurse practitioners, that transition was not going well, that they got to the adult side and they weren't as confident in treating these adults. They would treat their blood pressure, but they didn't feel comfortable about the autism piece. And so as we know, you can't tease out that piece of it. That makes the whole patient. So we're working right now, trying to find ways to build that transition to make it smoother. And so some of that is training of these providers that we're trying to now roll out. And so our grant is really about bringing everybody together to learn from each other. So yeah, that's Janice, if you're ever interested, you could always email me. I'll put my email down here if you're interested in becoming part of that, because that is a big problem. And I think how the best way to resolve that problem is by looking at it holistically, by bringing in the parents and the patients themselves to kind of say, this is what's happening. I'll put my email address there. Oops, sorry.
That's also, there's also a problem with taking children or adults to a dentist.
Yes.
Because
Yeah.
that's a noisy place anyway.
Yeah, and I think some of the tips that we talked about today also work for the dentist. Is that even just, I recommend that taking the child or the young adult to the dentist, even when they don't have to see the dentist, so just so that they could see the parent getting their cleaning, and just kind of sensitizing them to the environment, because there's a lot of shining, a lot of noise, and let's be honest, I don't even like going to the dentist. I'm still afraid to go to the dentist. Yeah.
There are some providers who do have experience. There's a group in Marietta called Urban Family Practice that is good. And if they have any psychiatric disorders, I usually refer them to the Emory Autism Center, which has a wonderful psychiatrist who has a very good familiarity with adults on the autism spectrum.
Yeah.
So those are just two resources.
Finding those resources to those providers, to Janice's point, that maybe are the more competent providers on autism, finding those providers is really key. So we have another dentist up, and I live outside of the perimeter, but there's a children's dental zone. I think it's in like a Johns Creek area, but they are more trained dentists towards autism, and they are very autism friendly. So
Laura, yeah.
Hi. So I just had some thoughts related to that, and I'm just speaking as an adult with autism. I know all of us are different, but I think there might be some commonalities. So for me, with my healthcare, it was gradual, and I think any transition plan should be gradual, like giving them independence and like a certain provider, like primary care physician. Okay, so this time and you'll be the one primarily asking the questions. And it also really helps having providers who acknowledge you as a person, because fortunately this hasn't as much been my experience, but I've heard of a lot of others who are on the spectrum who like the providers just address their parents. They pretend it's as if they're not even there. And that's just a very dehumanizing, belittling experience. I know most people aren't like that, but I think it just needs to be reiterated to all providers to treat their autistic patients just as they would anyone else. They're people, and that even if they don't have a lot of functional language, even if they're mostly nonverbal, they still in most cases have a lot of receptive language. So just talking to them, and like you said in your slide presentation, just saying in simple, direct terms, what is going to happen, what the purpose of the appointment is, so that they're in the loop, so they have a good understanding, and they're much more likely to feel more comfortable once they are addressed in that way. But yeah, for being an adult with dealing with health, honestly, I'm not great at it. Like I prioritize certain providers, like my mental health is number one. So for that, I wade through the insurance, which is something that I absolutely hate. But thankfully, working for CHOA, they make it much easier than it would be if I was working for anyone else. So the insurance provider and the employer makes a huge difference, because I had a previous employer whose insurance was much more difficult to navigate. But I think the main takeaway is for each piece that you want to involve the person with autism in, and kind of transitioning healthcare onto their plate of responsibility, it just needs to be done in pieces and be done gradually in a way that's not overwhelming, in a way that is direct, like here's a list of this, this, and this, like simple
Okay.
steps. That really helps.
Yeah, that's a great point, and that that we're still trying to kind of get that out there, is that it shouldn't be just like you're 21 now you have to learn all these new skills. It should be at 14, as parents and as clinicians, we should be trying to foster that within the adolescence, young adult, of like you tell me your history, you know, instead of deferring to mom or dad. It's like, and so kind of preparing them to be better healthcare consumers is really important. So that's
Right.
a great point, Laura. And
Right,
starting at
because I was
15, right, would be a
right, starting early. Because I was on my parents' insurance until I was like 28, I think. And it was only then, when I was thinking about getting my first job, that I understood just how weird the insurance works.
yeah.
Like that you pay so much out of pocket, and you pay hundreds and hundreds of dollars before you even have insurance kick in. And I remember telling my dad, like, this makes no sense. Why even have insurance if you're still going to pay this much money? It still kind of flabbergasted me, but I realized that I'm much luckier than most with my insurance package, but this isn't the case for everyone.
Yeah.
So, yeah.
How to even navigate insurance is a big one.
Yeah. Like healthcare isn't really the most challenging part for me. The most challenging part, at least before I got Choa's insurance, was the insurance. Like understanding why such and such isn't covered, having to call, oh my gosh, and you know, figure out why you're denied coverage, and just those phone calls and them directing you to another person who directs you to another person. And it's just, I mean, I can imagine it being extremely stressful for people who aren't autistic. So imagine throwing in being autistic into the mix. And it's, yeah, I'm hoping that eventually in the next few years, there'll be some type of reform, because the way it is for less generous plans is just absolutely ridiculous.
Thanks, Laura, for those insights and personal insights. Anyone else have any questions?
Hi, yes, I have a question. On the slide, you talked about ADHD and dramatic emotional reaction. How might those look differently in a child with autism?
Let me ask you this. What do you do, and how do you, what's your interaction with people with autism?
I work for the Department of Developmental Disabilities on the...
Oh, yeah.
Hi, Dr. Rubin. And with the hospital transition team, so we transition adults into the community from our state hospitals. And I have a daughter, 9 years old, that has autism.
Okay. Sorry to put you on the spot.
It's okay.
Yeah.
Context, right?
Yeah, no, I think it's important. Context is always important, you know, and as Laura said, you know, she sort of spoke about herself, and we get to understand each other better and communicate better. So here it is. Now, first of all, to say that whatever anybody can have can happen to individuals on the autism spectrum. And what individuals on the autism spectrum have, everybody else has. It just expresses itself a little differently. Now for ADHD, it's very interesting to me, having known kids like of all ages for long periods of time, is that very often at a very young age, the diagnosis is often ADHD rather than recognizing the child's characteristics of the autism spectrum. And why? Because there's a difficulty in focus. They go from one thing to another, and they're a little bit active, and they run and they climb and they jump and they do things and they bang into things and go upside down, and just generally very energetic children.
Yeah.
And so they often get diagnosed with ADHD before the characteristics of the autism spectrum become more obvious. And for the younger kids who are, let's say, under 5 years of age, the good news is that we generally don't use stimulant medication, because when you use stimulant medication, sometimes the kids can become more active or more aggressive or more irritable. So it doesn't always respond. So we often need to use something to help them calm down a little bit. And occupational therapy is such, I have such a faith in occupational therapy, particularly the sensory-based occupational therapy, because a lot of the ADHD symptomatology of kids on the autism spectrum is sensory-based. They need to feel held and cuddled and hang upside down and bang into things. They need a lot of sensory. And at the same time, they may be bothered by sounds, loud sounds, tastes and textures, much as I mentioned about the food preferences. So they're very sensory. So I find that if I can address the sensory issues of children on the autism spectrum who have the hyperactive symptom, ADHD symptomatology, they can improve significantly. So
Yeah.
that's just a little bit of it.
I agree in that. I feel like it's like this kind of search for like this fulfilling a sensory need. And so if you can find that what's going to meet that need, sometimes it's like kind of like redirecting the energy, right? And so if they're constantly searching for that to fill that sensory void that they're feeling, if we could find that, and then we could say like whether it's a weighted blanket or whether it's like these kind of like hanging things where they like a cocoon they can get into. And so it's almost like it's ADHD and it's like a hyperactivity to find that sensory need. So if you can find that, then you can decrease some of that hyperactivity too.
Ms. Williams, did I answer your question satisfactorily?
Yes.
Do I get a passing grade?
And also keep in mind that sensitivities can change over time. Like when I was a kid, I was extremely sensitive to fireworks. Like whenever my parents took me for 4th of July, it was painful. Every single time it went off, I would scream because it was painful. Now that I'm older, I can tolerate fireworks. There's still some sounds that are very unpleasant to me, but they're not actually painful. But some of those really intense stimulate fireworks or a gunshot, like it hurts when you hear it. But it does change over time. And also for me, like I find when I'm really stressed, that's when my sensitivities get worse, and that's when my ability to regulate my emotions get worse. Like when you feel like you're composed and good, like it's easier to tolerate things that you wouldn't otherwise be able to tolerate as well. So it can, it changes. It depends on mood. And I will say for me personally, the one big game changer for me was learning to regulate my emotions. And I wasn't able to fully do that until I was into my 30s. So please don't be discouraged. Just know it's very dynamic, the way that a person with autism develops, just as it is with anyone. But just because someone has a particularly severe sensitivity in childhood doesn't mean they always will.
Yeah.
Excellent point, Laura. I do see that a lot, particularly the hearing sensitivity. But I want to pick up on one other thing you mentioned, which is that under stress, you're much more sensitive, much more likely to be anxious, much more likely to have emotional reactions. And so it's so important to identify stress and reduce stress. And another thing I want to say is that we all feel like that. It's not unique. It's not absolute to people on the autism spectrum. And that's why I said that we all have a range of emotional expression. It just exhibits a little differently in people on the autism spectrum. Musu, you had a question?
Yes. So what is it about eggs? I mean, whether it's boiled or scrambled?
Sorry, can you speak a little bit louder? Sorry.
What is it about eggs? Like, whether it's boiled or scrambled? Like my son is so averse to it.
Yeah, you mean like he's so aversive to
just the smell, the texture. He just.
I'm with your son though. I have to say, I hate the smell of eggs too. That it smells like fish, but it's not fish; they're eggs. But so certain textures can be very triggering and aversive to people with autism. So if I can't stand that, if I don't like that smell, it's like 10 times more that they may not like that smell or that texture, that it feels rubbery, or with the scrambled eggs, the texture being different, a little too moist for them. So and that's where a lot of the the nutrition and the diet and feeding that Dr. Rubin was talking about earlier it makes that much more difficult when they have textures that they don't want to engage with, and so, or they only like the chicken nuggets, but they don't like this brand because the texture of the breadcrumbs is too much maybe for that brand.
The interesting thing is that, like, if I add the eggs to something else, he'll eat it, right? It's just the egg. It's, like that. If he sees that one is a no.
Yeah.
I've always wondered about it.
It's just an idiosyncrasy. Like for me, it's mayonnaise. I cannot stand mayonnaise. Like I actually, when I was a really, really little kid, I liked mayonnaise, but then I found out that it was eggs combined with milk, and that just was so disgusting to me. I could never touch mayonnaise ever again. Just the smell of it would make me feel nauseous. And it was just that knowledge that it was eggs combined with milk. I like eggs by themselves. Not a huge fan of milk, although I was born when I was a kid. But like I said, those sensitivities can change. Those preferences can change. Like when I was a kid, I hated deviled eggs. I thought they were, ugh. But now I like them. So his preference might change over time as he gets older.
Mm-hmm.
We've got 10 minutes left. If anybody else has any questions, now's the time.
I wanted to add back to the sensory that we're still finding out so much about the sensory aspect because it does vary widely. It does change over time. And, it's so complicated that, with a sensory, it could be a tag on a shirt would make them want to like claw out their skin. But I've also seen like that same child with that severe of a sensory to that sensation have a broken leg and not manifest. So talk about symptoms manifesting different in a child, that their leg was broken and we didn't know until we actually got the x-ray. And so they had a mild limp, but we thought, well, let's get an x-ray just to be safe, but probably not going to be broken, because if it's broken, they'd be in a lot of pain. And when you touched it, they'd scream, and they didn't. So it's so interesting that same child, the tag was the downfall, it was the most excruciating over a broken leg.
Yeah, it's really hard to explain, but like I hated turtlenecks when I was a kid. I could not wear itchy sweaters. Like I would take off my seatbelt because having it strapped across me was so uncomfortable that my mom was constantly looking in the back seat and like, put on your seatbelt, put on your seatbelt. And then I'd just kind of sneakily take it off because I just could not take that. But now that I'm older, I'm fine with it. There's still some things that I don't really like that much. Like I still don't like itchy sweaters, but it changes over time, and like it's peculiar to the individual. I think there was one more thing I was going to say, but I can't remember, so it couldn't have been that important.
So for me, I would say I think the sensory part was a huge factor initially, because my son would not let anybody touch him. It was just Dad and I that would touch him. But then once, with the OT and everything, and they started desensitizing him, that actually improved his relationship with his siblings, because then he would let them touch him. And the more he gets adapted to different sensory stuff, the more he's comfortable. Initial onset, he wouldn't go outside and stuff like that. But then the more you introduce him to things that he didn't like or he will scream, he got comfortable. And so he's much more comfortable now. And I think for us, we kind of realized how much that was really impacting his daily activities and him just living life. But I think he's doing much better with that being, he's getting adjusted to it.
That's great. Yeah, the desensitization just kind of over time, and maybe that's what for Laura, maybe some of those things that you are now better adapted to, maybe it was just, even if it wasn't intentional desensitization, it just was over time, to where now it's just you're more used to it perhaps. But it's sort of intentional desensitization, like working with an OT, can definitely help some. That's great to hear. Yeah.
And I know some people recommend things like exposure therapy. I think that needs to be used not like all at once. Like I think it needs to be gradually introduced, because I think like traditional exposure therapy can be much too overwhelming and aversive, and I think it might cause unnecessary trauma. So
Yeah.
just, you know, like as you described with your son, you know, it was gradual and he was able to get used to it in a gradual way. So I think that's the best way to help overcome sensitivities, especially in things that aren't avoidable in life,
Right.
is in small little doses to build up that desensitization so they could gradually to tolerate it.
That's a great point. Yeah, because it could be traumatic if it was done the wrong way, right? And
Right, right.
we don't want that.
That is so true, because there are many times we go out and we have to come back home, which
Mm.
the older ones never were fond of. But you know what? That's what it was. But the more we took him out and introduced him to different things, the more he liked it. But yeah, it's a process, definitely. It's not a one-day trip.
Yeah, for sure. Well, with our last remaining time, I guess I just was wondering, to Janice's point earlier, are there any things that, you know, Dr. Rubin and I could be doing differently, or we need to think about, or so what could we be doing maybe? What are there needs that need to be met that, you know, like, is anybody thinking like, you know, what needs to happen is X, Y, and Z?
Just continue doing what you're doing and educating other professionals so that they're as knowledgeable
Yes.
as you and providing care.
Thank you.
And
We need
you mentioned
not
earlier
only
about the anti-vaxxer movement. I'm not really sure what to do about that. That's very unfortunate.
I don't know either. I
Um,
don't know.
yeah,
Education is
Well, I think it's
yeah,
first the healthcare providers themselves. Some of them, they give the wrong information to parents. So if a healthcare provider is kind of, I mean, does have a reservation about you giving your child vaccines, you're going to think twice about it, because
right.
they're looked
yeah.
upon as authority in the sense wherein they know what is best for the child when it comes to their medical needs. And so if a healthcare provider has reservations, that parent
Right.
is going to have reservations. I think
Mm.
that's one thing. It's because there's so many things that do come into healthcare providers providing help to families, especially us with raising kids with autism. I think it is important for those healthcare providers to be fully informed first.
Yes, definitely.
Absolutely, because if you're looking to them, right? Janice, did you have something you want to add in?
Yeah, I was going to say, we're up in the North Georgia mountains, although I worked and lived for a long time in the metro area, and in some other sessions, which some of you other ladies have been in as well, and Joe, you were in as well. We've talked about the fact that there's not a lot of early identification. So, for example, you know, I have two boys right now, both of whom were only identified as mid-teens, by which time there was a lot of disinformation and there was a lot of kind of, oh, he'll grow out of it. So there was that part of it. And then the other part is just because of the kind of cultural background of poverty where we're at, there are some parents who do not have an expectation that their child will ever be a contributing member of society. And so, for example, we're already looking to be on disability because that seems to be the thing to do. So I don't know how we help people to set the bar higher, I guess is what I'm saying.
Break
Yeah,
the cycle.
yeah. There's
Yeah.
too often an assumption of limitations without, and when you put those limitations on the kid, then how do you expect them to excel if you already are
Right.
expecting them to fail? I
Right.
think that there needs to be more said about the potential of people with autism and
Yeah.
all the ways that they are able to contribute.
Sure. I mean, it's interesting. I have one boy who's very smart and has obviously done some research online. But one of the things he says is doesn't want to think about, he's almost 18, about being an adult, because autism is a degenerative disease and he will die.
Yeah.
It's like,
No,
wow.
He's convinced.
Yeah,
Totally convinced.
there's actually some professionals in the UK who are advocating for changing up from talking about autism spectrum disorder and speaking more of autism spectrum condition,
Right.
Yeah,
to emphasize it
that's
as a difference and not as a disability. I mean, yes, there are some
Right.
things that are disabling. Like when I was not able to regulate my emotions and
Sure.
meltdown, like that was disabling. But I was able to learn a different way of,
Mhm.
coping with that. And over time, with the right treatment, with the right therapy, I was able to overcome that. So it shouldn't be thought of as a death sentence. It should be
No.
thought of as an opportunity.
I
I
think that's
think
right.
I like that. I think that's a perfect ending to this meeting, because for many years I used the term autism spectrum condition for the very reasons that you mentioned. But when the DSM-5 came along, said autism spectrum disorder. So we're all kind of compelled to do that. And what's nice about language is that it changes. So it
Yes.
changes over the course of time. So if over the course of time, I'm going to expect that the term autism spectrum disorder is going to change over the course of time. There will be a new language and a new understanding, and new language helps us to think differently.
Yeah.
And again, I think it's a condition that can become a disorder, as many of us can have, even if we don't have an autism spectrum condition,
That's
we can
right.
have a disorder. So
Correct.
it really becomes much more flexible.
It's another opportunity. I love that, Laura.
Definitely. Thank you.
Well, I
All right,
think
I gotta get back to work. Bye, guys. Thank you.
Bye.
I think
Weren't you working now? You were working.
Oh,
You've been working
true.
this past hour. You've been working
Yeah.
very
True.
hard.
That is true. Thank you for all the information. Y'all take care. Bye.
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 Thank you.
thank you,
Bye,
everybody.
everybody. Thank you for being a
Bye.
good audience. And
Feel free to reach out to us if you have any questions. The recording is going to be made available. And there was a request for the PowerPoints for those that came in late, which I'm happy to share any information.
All right. Thank you so much.
Thank you.
bye, everybody.
Bye.
Keep up the good work.
Bye.
Bye,
Great.
Ms. Williams. Nice to see you again.
See you too.
The best audience